Can we start?
Yes, sir. It's rerouting, sir. Just 15 seconds.
Okay.
Yeah, done, sir. You can start. You
Okay,
can
bro.
start.
Please go ahead.
Okay, good morning, sir. My topic for today is altered mental status in the critically ill approach to diagnosis and management. And my moderator is Gansham, sir. I thank Gansham, sir, and Srinivas, sir, for giving me this opportunity. So, slides are not moving. Okay. So what is altered mental status? Altered mental status, various terms which we use for altered mental status in our clinical practice, like acute confusional state, confusion, acute brain failure, encephalopathy, and disorientation. Another term which we commonly use is delirium, which is a more specific descriptor for an acute, usually fluctuating altered mental status. It is characterized by a decline in attention, that is inattention, additional cognitive deficit, or altered level of arousal. The differential diagnosis of altered mental status includes the conditions that are both life-threatening and they are at the same time reversible also. So a systematic approach to the patient is a key. Then there are three main mechanisms for altered mental status in any patient. One is structural brain lesions, then diffuse neuronal dysfunction, which can be secondary to some systemic pathology, and rarely there are psychiatric causes, which you can elicit from the history mostly. So, the most prevalent etiology of a non traumatic coma is ischemic or hemorrhagic stroke, followed by anoxic injury, then poisoning, then metabolic causes. So, non structural causes, they generally outnumber the structural causes. The non structural causes are around 37 to 75% versus 28 to 64% structural causes. So, we use various scales and measures for the level of consciousness. The maneuver which you use to elicit the response of the patient, it should be adequate stimuli without inducing actual tissue damage. So there are various scales which we use in our clinical practice. The most common being the GCS, Glasgow Coma Scale. You use the best score. Then you have four score, full outline of unresponsiveness. AVPU, awake, verbal, pain, unresponsive. One of the four you grade the patient in, and there is a similar to AVPU. You have alert, confused, drowsy, unresponsive scales. So you have the GCS score, which we all of us use in our clinical practice. You first check for factors interfering with communication and the ability to respond and other injuries. Then you observe the response if there is eye opening or the content of speech and movements of the patient. Then you stimulate. If you don't find a response, you stimulate the patient through sound, then a shouted request, then a physical stimulus. And the rate you assign based on the patient's response, the best response. So we have this new GCSP score which we use now. It is mostly similar, but the changes are that it is EVM. So motor is the same. Verbal mein there are changes like 5 is for orientation, 4 is for confused, 3 is for response to words. Words, the patient speaks words, and 2 is the sounds, and 1 is none. Then opening, eye opening, it can spontaneous, then 2 speech, then 2 is eye opening to pressure, and then none. So these are the changes in the new scale. Pupils unreactive, pupil also for GCSP, if they give a score of 2, one pupil 1, and neither pupil 0. So you subtract this pupil score from the actual GCS to get the GCSP score. So then you have the four score, which includes eye response, motor response, brainstem reflexes, and respiration. Four score incorporates brainstem reflexes. There is no verbal component in four score, and as compared to GCS, it has been found there is good inter-observer agreement. So now our initial approach to altered mental status, what it should be is first the initial evaluation. So first of all, the patient comes to you, you look for the vital signs, you secure the airway, breathing and circulation. then check blood glucose levels side by side. All this should happen. Check blood glucose levels. Consider naloxone in case of opioid poisoning if you are suspecting that. Then check electrolytes, sodium, potassium chloride, bicarb, calcium, magnesium, phosphorus, a CBC, urine toxicology, RFTs, LFTs, including albumin. Send urine analysis with culture. Then chest radiograph, focused history on the basis the baseline cognitive function of the patient and the time course from which the patient has the symptoms. Physical examination to look for focal neurological deficits. Then subsequent evaluation, you look for the brain imaging with CT. If you don't get anything in CT, then MRI or LP performed after high suspicion of infection. Then you check for serum ammonia, thyroid function tests, vitamin B12, autoimmune serologies, blood cultures should be sent if you are suspecting any sort of infection, especially in case of meningitis. Then an EEG should be performed initially if there is a high suspicion of status epilepticus or non-convulsive status epilepticus. So then on the in the we begin with the history in the evaluation. So after stabilizing the patient, you retrospect and go back to the history that what led to this. So attempt to solicit and record the history, the time of onset of the illness, time and acuity of onset, any fluctuations, evolution, how it evolved, associated symptoms of headache, fever, seizures, nausea, vomiting, any change in motor activity, changes in speech, content, and pattern, past history, any similar events in the past. Does the patient have chronic neurological deficits, HIV status, family history, including neurologic and is on what dose, any recent alterations in the medications or in its dosage. Then social history, does the patient take alcohol or any drug history? In the physical examination, the general physical examination often gives various clues to non-neurological causes of to head and neck, any sense of trauma, any tenderness, any meningismus. Then cardiac examination should include a proper volume status assessment, especially if the patient is in shock, the inspection of the JVP or your IVC in the pocus and extremities, your auscultation of the heart to assess for any murmurs or look for any MR in your pocus to hint at some endocarditis or some valvular vegetations. So, auscultation of the lungs may reveal evidence of volume overload or infection. Then palpation of the back also is important, which you find out if there is some point tenderness of over the spinous process. So that could hint at some epidural abscess or any tenderness over the kidneys, as in pyelonephritis. Abdominal examination to demonstrate ascites or tenderness, and a careful skin examination for any stigmata of IV drug use or liver disease like icterus or spider angiomata in case of liver diseases. So neurological examination, you look at the level of consciousness, your pupillary response, motor response, your pattern of breathing is also important. Check for the fundus or ONSD and meningeal signs. Then if the patient is moving all four extremities, the reflexes, any signs of impending herniation, which is a ultimate threat to life, hypertension, bradycardia, irregular respirations, any sort of posturing, dilated pupils, all these are signs of impending herniation. Then breathing pattern of the patient, if it is regular, Cheyne-Stokes irregular, or if there is apnea. Any toxidromes like vital signs, pupils, skin, if the patient, if the presentation fits in any of the toxidromes of poisonings. Then, if there are any signs of shock, any clear signs of trauma, look at the abdomen in case of any obvious pain or some masses if you're suspecting. Then the mental status examination, sometimes, especially in admitted patients, or the patient can present from home also with delirium. So the gold research criteria for diagnosis of delirium is a DSM-5 criteria. Plus scale is the CAM, which we also use in our clinical practice, which includes four components: acute onset and fluctuating course, inattention, disorganized thinking, and altered level of consciousness. Because this CAM score, it compared with the DSM, it has a high specificity for delirium diagnosis, and it is very efficient, and it can be administered by the nurses also. It is a variety of healthcare professionals. And the adaptation of CAM, which is for ICUs, is the CAM ICU score scale. So this is the CAM ICU score, which we use in the ICU. Any acute change or fluctuating course of mental status, you say that there is no delirium. If it is not there, then no delirium. Then you check for inattention, then altered level of consciousness. If there are more than two errors, then you go for the RAS level. If it is zero, then there is no delirium. If the RAS is uh, other than zero, then it is positive for delirium. And if the RAS is zero, then you ask patient to check for disorganized thinking. Such questions like, will a stone float on water? Are there fish in the sea? So if there are more than one errors, then CAM ICU is positive. You say that it is delirium. And if the errors are 0 to 1, then there is no delirium. Just one new or hyperactive. So there is score of 0 to 4 for each of these four parameters. Then abbreviated mental state. You ask the patient their age, date of birth, place, the name of the hospital, building, current year. Then you check for attention. You tell them to recite the month of the year in a backward, like in the reverse order from December, November. Then any acute cognitive functions, power, hallucinations arising in the last 2 weeks, and it is still evident in the last 24 hours. So they give a score of 0 to 4 for each of these. And if the total score comes out to be more than 4, then you say that delirium is positive. If it is 1 to 3, you say that there is some cognitive dysfunction. And if it is 0, then there is no delirium. So, in the process of evaluation, one should remain vigilant for several key features associated with altered mental status, which include thiamine deficiency. The patient may present with gaze palsies, nystagmus, ataxia, and there is myoclonus or asterexis. So that is also a presentation which may be caused by uremia, sometimes hyperammonemia, sometimes medications which we use in the ICU. They may also cause myoclonus or asterexis, some of them being cefepime, benzodiazepines. So this is a simple mnemonic to help you assess a patient of altered mental status, vitamin E, so that you don't miss anything. Sometimes when you're stuck and you don't find that, sometimes the evaluation in these patients is very challenging, that you've done everything and you're not able to find the cause of altered mental status. So it kind of helps you to rule out everything. So V is for vascular, stroke, SH, any hypertensive emergency, or press, cerebral amyloid angiopathy, vasculitis. Then infectious causes, all any sort of infection, including meningitis, UTI, any other source of infection causing septic encephalopathy. Then traumatic, post-traumatic encephalopathy in itself is an entity, SDH. Then toxic intoxication, drug withdrawal. Some medications can also cause, some prescription drugs, some over-the-counter drugs like paracetamol poisoning is also there. So autoimmune, like vasculitis, SLE, responsive encephalopathy with autoimmune thyroiditis, also called Hashimoto's encephalopathy, acute disseminated encephalomyelitis, autoimmune limbic encephalitis. Then metabolic causes, there are a number of causes like hypernatremia, calcium, magnesium, any derangements in those. Then blood sugars, hyperthyroidism, adrenal crisis, Cushing's, uremic, hepatic NCAF. Then thiamine or cobalamin deficiency is also very important. Hypoxia, hypercarbia in itself can cause that. Then iatrogenic causes like day-night dysregulation. Sometimes it's just sleep deprivation, and you give some melatonin to the patient. The sleep is corrected. Day-night, you give good sunlight exposure, and the delirium gets corrected. So in few days, then sensory deprivation, limited mobility, surgery, untreated pain, polypharmacy, use of several drugs like anticholinergics, antihistaminics, benzodiazepines, steroids themselves. They can cause steroid-induced psychosis in high doses. Fluoroquinolone, cephalosporin, antibiotics. All these things can precipitate altered mental state, especially when used in combination. Then and you stop the drug, and in some time the patient becomes better. So neoplastic etiologies like intracranial neoplasm, paraneoplastic encephalitis, carcinomatous meningitis, neurodegenerative diseases, then epileptic, of course, non-convulsive, and post-ictal state. So, so in the evaluation, CT of the brain is an appropriate screen for ICH, hydrocephalus, of course, or a large mass, or any vascular imaging of the head and neck. CT followed by the vascular imaging to look for if there is any concern for stroke. Then, if the CT does not reveal an obvious precipitant for the altered mental status, then MRI brain with gadolinium should be pursued. If after a head CT should be obtained before LP in patients of altered mental status if you're suspecting meningitis. And LP is the most useful in patients who present to the emergency department, and also in neurosurgical patients with a skull fracture if they have a device or an EVD in situ. So that can also cause meningitis, sometimes hospital acquired meningitis. So it is reasonable to have a low threshold to start empiric antibiotics in cases of bacterial and viral meningitis, because these diseases, they have a very high morbidity and mortality. So it is best, if you're suspecting them, start them, and then if you rule out with the CSF, then you can stop later. So in the setting of infection, CSF may sometimes only be mildly abnormal within the first 24 hours of symptom onset, or even normal. Sometimes in cases of like in HSV encephalitis, in the first 24 hours, the CSF comes out to be normal. So for this reason, if one has a high suspicion of meningitis or encephalitis, the LP should be repeated 72 hours later if you have a strong clinical suspicion for these meningitis. Then abnormal CSF may also point towards autoimmune encephalitis, sometimes paraneoplastic encephalitis, or neoplastic etiologies. So the detection of autoimmune encephalitis these days is increasing over time because we are doing more frequent testing and identifying new anti or auto antibodies. So, and it has also been found in some Western literature that the prevalence and incidence of autoimmune was similar to infectious encephalitis. So, if you test it, you come to know. So, it can be helpful to test for oligoclonal bands or IgG index in both CSF and serum. Sometimes there is no pleocytosis, and only there is raised to point chest, abdomen, and pelvis sometimes to test for autoantibodies on serum, and CSF should be considered if you get inflammation. Carcinomatous meningitis is also a consideration, which may present with focal findings. Sometimes these patients present with cranial nerve deficits and ataxia. So it is more likely to be found in patients with lymphomas. These sorts of malignancies can cause like lymphoma, leukemia, in melanoma, in lung and breast cancer. They can present with carcinomatous meningitis. So if there is a history, then obviously you're suspecting and you should do a workup for that. Although MRI may show abnormal enhancement in these patients, including of the cranial nerves or of the nerve roots, uh, you should obtain both CSF cytology and flow cytometry in these cases. If you're suspecting carcinomatous meningitis, obviously it increases the sensitivity of detection. So the risk factors for seizure include any history of prior seizure, any mass, any infection, and so it is reasonable to obtain EEG in all these patients. In addition to the initial workup, other metabolic abnormalities should also be ruled out, like hypernatremia, vitamin B12 deficiency. All these should be considered. Endocrinopathies such as hyperthyroidism, autoimmune thyroiditis like Hashimoto's encephalitis, these should be considered if antithyroid antibodies are present in the right clinical context. So now coming to the metabolic encephalopathies, the two most common metabolic encephalopathies which we encounter are hepatic encephalopathy. For hepatic enceph, you use there are two main scorings. The most common is the West Haven criteria. You have four grades of encephalopathy. One is altered sleep pattern. Grade two, you have asterexis, time disorientation. Grade three, there is somnolence to semi-stupor. The patient is responsive to stimuli. There is time and place disorientation. And grade four is complete coma. So then you have this modified Parson and Smith grading. It includes GCS also as one of the components. So GCS of 15 is grade 0 with only some it is only you get neurological signs on some psychometric testing. Otherwise, that is grade 0. Then one is trivial lack of awareness with a GCS of 15, shortened attention span. Two is 11 to 15 GCS, lethargy, disorientation, personality change. Three is confusion, somnolence to semi-stupor. The GCS falls to 8 to 11, and if the GCS is less than 8, then it is coma. So there are three types of HE, hepatic encephalopathy. Hepatic encephalopathy type A is hepatic encephalopathy associated with acute liver failure, and type B is encephalopathy associated with portal systemic bypass, and there is no hepatocellular disease. So it is only portal systemic bypass. And type C is HE in patients with cirrhosis and portal hypertension or portosystemic shunts. In that also you have minimal episodic and persistent HE. So the management of HE, we all know it is first secure. If it is grade 3, grade 4, you secure the airway, breathing, circulation. Then you look for any infection, you treat it. Diuretics, dehydration. If in case of volume expand, if the patient is dehydrated, you give volume expansion. There is GI bleed, control it. In case of constipation, give laxatives. Obviously, lactulose is the mainstay initially for management. In case of alcohol binge, thiamine, then correct or electrolytes, correct nutrition. Rifaximin and lactulose is the standard therapy, and sometimes you may need embolization of large spontaneous portosystemic shunts if they are present. Then, according to local availability and practice, you use branched chain amino acids, polyclean glycol, hepamers, and albumin or extracorporeal albumin dialysis. So, uremic encephalopathy, development of uremic encephalopathy may occur if when the GFR is less than normal by 10%. It is more severe with acute patients than with chronic patients, and patients with HRS are at higher risks of uremic encaph. Now, some facts about uremic encephalopathy: the level of blood urea nitrogen can vary widely. It is the acuity of onset which governs the presentation. Then tremors, asterixis, and delirium they may present with. Sometimes they may present with hemiparesis. Some patients they are free of cerebral symptoms even at a burn of 200 milligrams per DL. So uremic patients they are mostly deficient in thiamine. So in case of uremic NCAF also you need to give thiamine to these patients. So, neurological recovery following an effective dialysis does not occur immediately. It takes time, and uremia and hypertensive encephalopathy simultaneously they are difficult to diagnose. So, the presentation is with seizures and myoclonus. There is asterixis, myoclonus, and it is exacerbated by electrolyte abnormalities, which are commonly present in these patients who are uremic, like hyponatremia and hypocalcemia. Then one entity is disequilibrium syndrome. It is the occurrence of neurological signs and symptoms which are attributed to cerebral edema during or following shortly, sometimes around 8 hours after intermittent hemodialysis. And why does this occur? It is due to sudden clearing of nitrogenous compounds from the blood and increase in the urea content in brain, which leads to raised ICP. So, symptoms include confusion, headache, just nausea, vomiting sometimes, tremors, and myoclonic seizures, and they usually resolve spontaneously within days. Then one entity is dialysis dementia, which we don't encounter these days, but it used to occur initially. It was a neurological syndrome that occurred in some long-term patients who were on 2 to 3 years on dialysis, because there used to occur aluminum intoxication because of aluminum containing compounds in the dialysis fluid. So the symptoms could be permanent memory loss. They used to be dysarthria, facial grimacing, myoclonus, mood and personality changes, and usually death used to occur within 6 months from diagnosis. So it was a fatal disease. So now after all this, we'll discuss few interesting cases to increase your understanding of how to approach in patients of altered mental status. Like there was a patient who was an 18-year-old boy who was previously well. The complaints were that he started having headache and he became lethargic for 3 days. Then he started having blurring of vision and he had status epilepticus. So he was intubated at a district hospital, and his seizure was aborted with IV lorazepam, and he was started on midazolam infusion. So he came to the tertiary care center, and on arrival, he was sedated. Pupils were equal and reactive. Fundus was also normal. There was no focal neurological deficit. There was hypertension, but there was no bradycardia. So the CT was done, and it showed mild cerebral edema. So he was weaned off sedation, but the child remained encephalopathic with persistent hypertension. Urine routine showed RBCs in the urine of more than 5, and the anti-streptolysin O titers were done because they were urine, so it could be glomerulonephritis. Then the titers came out to be 800. So this was hypertensive encephalopathy secondary to post-streptococcal acute glomerulonephritis. So you should suspect such things in young patients. Then press posterior reversible encephalopathy syndrome. So it is associated with various conditions. The pathophysiology is still not well known, but conditions like immunosuppressive or cytotoxic drugs, hypertensive encephalopathy, especially in pregnant females, preeclampsia, eclampsia, and HELP syndrome, autoimmune disorders like SLE, acute or chronic renal diseases, HUS, TTP, high dose steroids, then liver failure, transplantation, post transplant patients, some endocrine dysfunction, hypercalcemia or hyperparathyroidism, then post bone marrow transplant, massive blood transfusion, sometimes in cases of porphyrias also. So, the pathogenesis, so far as has been elucidated, is that sometimes hypertension or autoimmune diseases or cytotoxic drugs, steroids, or endocrine dysfunction are the culprit, and there occurs release of free radical cytokines. There is cerebral endothelial damage causing vasogenic edema, sometimes severe hypertension and brain hyperperfusion and endothelial injury, or causing vasogenic edema, cerebral vasoconstriction, which causes brain hyperperfusion, then cerebral ischemia. The vasogenic edema causes dysfunction of microcirculation. There is hypoxia, there is cytotoxic edema, and neuronal cell death. So, clinical presentation sometimes in these patients is with headache, some visual disturbances will be there. Sometimes they can have seizures or altered sensorium. The patient can a pregnant female presenting with seizures or altered sensorium with preeclampsia, eclampsia, HELP syndrome in the background. Okay, patients with chronic hypertension, autoimmune disease, renal failure, especially those patients on high dose steroids or cytotoxic drugs. So once you confirm it, the treatment is symptomatic management only. Correct blood pressure, withdraw the cytotoxic drugs. If the patient is, if it's a pregnant female, then prompt delivery by cesarean section for preeclampsia, eclampsia, and HELP. Then correction of metabolic derangements. You may do dialysis if required. Then antihypertensives, antiepileptics in case of seizures, and correction of coagulopathy, low platelet count by FFP. So basically, it is now it is increasingly being recognized due to better imaging techniques. Pathophysiology is not completely elucidated, and management protocols, they need to be specific and well defined, especially in obstetric cases. The current research questions for press are that it can be that can press be predicted from early signs and symptoms in high risk cases. We can't probably still not till now we don't know. Then what is the pathophysiology of press? Do early intervention treatment and intensive care have any effect on the prognosis of these patients? We don't know as of now. So then another case, a 52-year-old woman, she presented with low-grade fever, headache, disorientation. She had some amnesia. There was poor response to communication. There was numbness in the right hand, blurred vision in the right eye, and tonic-clonic seizures in the previous 2 weeks she had. So her previous neurological history was just unremarkable. Her physical examination revealed horizontal nystagmus, bilateral Babinski signs, then 4 by 5 of limb power was there, and on mental state, her mental status examination was unconclusive because she was not cooperating. So, what I wanted to say is that patients of Hashimoto's encephalopathy, they have varied presentation. This patient has almost everything, and it was quite varied. So, this is called steroid responsive acute or subacute encephalopathy associated with antithyroid antibodies. The presenting features vary widely in Hashimoto's encephalitis. So, in patients who present with altered mental status, especially with a history of hypothyroidism, sometimes they don't give a history, you should suspect it. You should send for anti-TPO antibodies and thyroglobulin antibodies. Sometimes they have around 60% of patients, they'll just have psychiatric symptoms. So, mostly TSH should be high in these patients, but these patients sometimes may be euthyroid or hypothyroid also. Then myxedema coma. Coma obviously is a misnomer. Sometimes these patients don't have coma, but it is just a decompensated hypothyroidism, acute or subacute, and precipitated by stress, especially. The patient is hypothermic, hypoventilating, is in suspended animation. From compensated hypothyroidism, the patient shifts to decompensated hypothyroidism with stress factors like sepsis, cold exposure, sometimes surgery, burns, trauma, medicine non-adherence. So these patients present with the delirium, hypothermia, bradycardia, shock, hypoglycemia. Another differential of altered mental status sometimes is CO2 narcosis. The main symptoms of CO2 narcosis, they are visual, dimmed sight. The patient complains of reduced hearing, shortness of breath. There are tremors. Central symptoms like dizziness, confusion, headache. There is drowsiness. Sometimes they are unconscious. There'll be excessive sweating, and obviously there is increased heart rate and blood pressure. So the degree of CO2 retention correlates the most with the symptoms, duration of the condition, and headache, confusion, and somnolence. PCO2 should be always gradually corrected. Then there are febrile syndromes which present as encephalopathy. You have the serotonin and neuroleptic malignant syndrome. So serotonin syndrome is precipitated by SSRIs, tricyclic antidepressants, and MAO inhibitors like selegiline and all. And neuroleptic malignant syndrome, it is precipitated by neuroleptics like metoclopramide, sometimes amoxapine, sudden dopaminergic drug withdrawal. Like you have a patient of Parkinsonism who was on Syndopa, carbidopa, and the patient stops taking the medications. So sometimes these patients like can present with NMS. So mechanism, serotonin syndrome is 5-HT receptors overstimulation, and for neuroleptic malignant syndrome, it is D2 receptor blockade. Onset is different. For serotonin syndrome, it is mostly within 24 hours, and for NMS, it is more gradual within 7 days. The symptoms are almost similar, like autonomic, mental, neurological symptoms. But in serotonin syndrome, there'll be myoclonus, there'll be diarrhea, nausea, some shivering. In NMS, there'll be hypersalivation, incontinence. So temperature more than 38 degrees Celsius in NMS, there'll be akinesia, there'll be extrapyramidal rigidity. In serotonin syndrome, there'll be dilated pupils, there'll be hyperreflexia. Creatinine kinase is mostly raised, but it is more higher in NMS. Then WBCs are also raised. Then disease severity. The disease in serotonin syndrome, it can be mild to severe, and NMS is more severe mostly. Most cases, they require ICU admission. So there are serious complications of both of these, and they are more or less similar. In you will have you can have DIC. In serotonin syndrome can have both raised counts, or they can be leukopenia also. They can be thrombocytopenia, seizures, multi-organ failure, rhabdomyolysis, and in NMS, it can have AKI, rhabdomyolysis, MI, sepsis, cerebellar neuronal degeneration sometimes. So the main treatment is discontinue the causative agent, and the rest is all supportive. Some specific treatments are also there, like cyproheptadine, benzodiazepines in case of serotonin syndrome. For neuroleptic malignant syndrome, you use dopamine agonists, obviously carbodopa, levodopa, dantrolene, bromocriptine, all these are there. So the onset of NMS is gradual and the recovery is also gradual. Recovery of NMS is over 2 to 14 days. For serotonin syndrome, mostly they recover within 24 hours. So mortality is higher obviously with NMS because it is the more severe of the two. Then one entity is hypertensive encephalopathy. which is a rare condition characterized by high blood pressure and neurological symptoms, including transient disturbances of speech or vision. Sometimes these patients have paresthesia, disorientation, they can have seizures, loss of consciousness, and papilledema. So, focal neurological deficits, focal or generalized seizures, sometimes nystagmus, sometimes there'll be just a severe headache, nausea, vomiting, visual disturbances, confusion, irritability, and altered mental status due to cerebrovascular spasm. There can be focal or generalized weakness. So the management is obviously reduce MAP by 20 to 25% and do not exceed this within the first 30 to 60 minutes. Then treatment reduces vasospasm that occurs at these high pressures, and but you should always avoid excessive blood pressure reduction to prevent hypoperfusion of the brain and further cerebral ischemia. So there are various conditions which can be precipitated by hypertension, like acute ischemic stroke. So the treatment mostly the drugs preferred are nicardipine, labetalol, and esmolol in most cases. The goal in acute ischemic stroke is you must treat when it is more than 220 by 120, except with thrombolytics, the limit is more than 185 by 110. Then excessive BP decrease may worsen ischemia, so that is the reason. Then ICH MAP you have to target around 130 because precipitous BP fall may increase mortality. SAH target is the systolic BP less than 160 and keep systolic BP at least more than 120 to maintain cerebral perfusion. And in case of hypertensive encephalopathy, decrease the MAP by 15 to 20%, and aggressive blood pressure again leads to hypoperfusion. Then one more entity is non-convulsive status epilepticus, which presents as encephalopathy. There is no universally accepted definition of NCSE, and there is no consensus on how to treat it. EEG is although critical to the evaluation, but it can sometimes be equivocal. So, patient's clinical state, the medical history, and response to anti-seizure drugs is often needed to make the diagnosis. Sometimes it can be a tumor. It can be a tumor because of the surrounding edema, is precipitating non-convulsive status epilepticus. These are the structural causes. Non-structural causes, sometimes as simple as a sepsis causing septic encephalopathy, can present as an NCSE. So when your sepsis resolves, your NCSE also corrects. So serial EEG monitoring is the key in these patients. So clinical features of NCSE are altered mental status, most commonly confusion, coma, lethargy, memory loss, then speech disturbance, myoclonus, followed by unusual behavior, sometimes anxiety, agitation, and delirium, sometimes extrapyramidal sometimes symptoms, and sometimes it is as simple as hallucinations. So treatment of non-convulsive status epilepticus is first, you have these tier 1 medications, which are benzodiazepines, levetiracetam, valproate, fosphenytoin, lacosamide, and brivaracetam. First, you give a full load of any one of these medications. Then you move, as soon as it is not working, then move to the next medication of the tier 1. If that is not working, then tier 2, that is phenobarbital. Then, if there is cessation, then fine. If no, and coma or stupor is there or it's high seizure burden, then you go for IV anesthetics, which are midazolam, propofol, ketamine, pentobarbital. Mostly in clinical practice, once you start midazolam and you increase the dose to 10 to 15, then blood pressure starts falling. So you have to use ketamine in these cases. Then, if the patient is settled, then you can go for enteral seizure medications like perampanel, pregabalin, then tier 2 clobazam, topiramate, then the tier 3 medications oxcarbazepine, carbazepine, clonazepam, and vigabatrin. So that is there. Now, a quick word about the pupils. So, in these patients, that is also important to look for the pupils and your interpretation of that, your inference from that. So, if there are small pupils less than 2 mm, suspect opioid toxicity or a pontine lesion. Pupil size, mid-sized pupils 4 to 6 mm, unresponsive to light, could be a midbrain lesion. Maximally dilated pupils more than 8 mm could be in case of drug toxicity, for example, anticholinergic overdose. Mixed and dilated pupils, third oculomotor nerve lesion from uncal herniation. So now, what could be fatal at once in a patient with altered mental status? Cardiac arrest, airway obstruction, So rule out these things first. Breathing, oxygenation. Then what could be fatal in the next few minutes? Hypoglycemia. So look for blood sugars, overdose of any drug. So you need to secure the airway in those cases. Make the patient stable, ensure ABC, and then look at the history, interrogate the relatives to find out what they have taken, so that if there is an antidote, you can give it. Intracranial hypertension and herniation. So these are the conditions which are fatal in the next few minutes. Then what could be fatal in the next 10 minutes? So still the ABCs first, then hypotension, anaphylaxis, hyperkalemia, acute MI, and aortic disorders. Then, what could be fatal in the next few hours? So, you have stroke, ICH, sepsis, alcohol withdrawal, status epilepticus, metabolic encephalopathies, and others. So, always you should rule out the more fatal and things first, followed by the lesser ones. So, to sum up, first, the ABC is always in patients with altered sensorium, vitals, blood sugar, then history, attention to the baseline cognitive status, change in medication, any change, recent change in medication, look for the in examination, look for signs of structural causes, focal neurological deficits, then ABG, CBC, LFT, RFT, including calcium, magnesium, ECG, chest X-ray, toxicology screen, should be done. Step 3 is CT. If you don't get anything, followed by MRI. If indicated, then LP. Step 4 is guided by findings on the initial evaluation. Your serum ammonia, your thyroid function test, your morning cortisol, ANA, antithyroid peroxidase antibodies, and EEG. So initial investigations, what you after this workup, what initial investigations you will send in an unconscious patient? A full blood count, blood glucose, urea and electrolytes, and serum calcium, LFTs, clotting screen. All these questions when the exam going candidates, when you are there in the viva, the examiner asks that, oh, okay, now what evaluation you do, then what investigations you will send. So you should tell all these investigations with the rationale, like serum calcium, LFTs, clotting screen, then toxicology. What toxicology, including PCM, salicylate, blood alcohol levels, ECG, the most common ones. Then chest X-ray, ABG, including carbon monoxide concentration. Blood cultures should be taken in patients with fever or suspected sepsis, preferably before the administration of empirical antibiotics. And other microbiology samples should be taken based on the clinical assessment. Treatment obviously is you should ensure oxygenation, circulation control, glucose, lower ICP, stop seizures, treat infection, restore the acid-base balance and electrolyte balance, adjust body temperature, administer thiamine, consider specific antidotes, naloxone, flumazenil in case of benzodiazepine, flumazenil in case of opioid naloxone, and control the agitation. So, take home message is that unconsciousness is a time sensitive medical emergency where early psychological stability and diagnosis are vital in optimizing patient outcomes. And initial assessment of airway, breathing, and circulation must be performed to identify and manage the most immediate threats to life. The immediate threats to life are the most important ones always. All facets of care, history, examination, investigations, and treatment management should be delivered in parallel by a team working in a systematic way, even in the apparent absence of trauma, especially in older patients or patients taking anticoagulations, brain injury or intracranial hemorrhage or trauma should still be considered. Thank you.
Kancham?
Thank you, Apurva. Uh, I think it was quite an extensive list of things that one should be aware of while dealing with altered sensorium, especially when patients come to the intensive care unit. I think many a time, you can have a different subset of patients. One subset of patients which or who present to us with altered sensorium, and then you have another subset of patients who are having a good GCS at presentation, but during the course of illness or during the stay of the ICU, they may have altered sensorium. Uh, I think the key, or the core on which most of us we depend on managing these patients is to one is neuroimaging, right, and then CSF analysis. But most of us, once this neuroimaging and CSF analysis is normal, then most of us don't know what to do or where to go. But you have highlighted quite a few points which we need to be aware of, especially when you have a normal imaging and normal CSF finding. See, from the intensive care perspective, thiamine deficiency, especially refeeding syndrome, is something which is very common. Uh,
Yes, sir.
the incidence is as high as almost 70 to 80% in the reported literature. So that is one thing that we should be aware of. And supplementing thiamine is a very, very simple way. Keep a watch on what's happening with your potassium and phosphorus. If you find that there is a reduction in your phosphorus and potassium with the initiation of feast, always think about refeeding syndrome. Second thing, the point about the EEG. See, most of the times, if you want to diagnose non-convulsive status epilepticus, then it has to be a continuous EEG. We just do one EEG and then we kind of, if it doesn't pick up, the chances of a stat EEG picking up a non-convulsive convulsive status can be very low. So we need to have continuous monitoring of EEG, right? Third thing, yes, delirium is a very, very important and common thing. So ensuring sedation in such a way that the sleep cycle is maintained, right? Uh, Giving frequent breaks from the sedation and trying to see if we can some way duplicate or emulate the sleep cycle is something which we have to try and do it. And lastly, one thing that we have seen very commonly in our areas, in our ICUs, is of late the addictions have gone up. I mean, alcohol withdrawal has become very, very rampant. Uh, Lots of patients who are addicted to alcohol, and alcohol withdrawal is one of the most common causes of altered sensorium in our ICUs. Similarly, I think the availability of different recreational drugs has gone up significantly, and many
Yes.
times you may not be getting that history until unless you probe it, with greater
Mm.
detail. So these are the few things which I thought we should be aware of. Seniors.
Yeah, I think it was one of the most extensive altered sensorium comprehensive review. I think a lot of learning points for all of us. Only point I would like to add is when we talk about dyselectrolytemias causing altered sensorium, we always speak about sodium hyponatremia and hypernatremia. But in intensive care patients, especially the CKD patients, the malignancy patients, hypo and hypercalcemia should always be considered if you are unable to crack the diagnostic dilemma of why a patient is having an altered sensorium, and the clue usually lies in the QT interval of the ECG. Such clues are always there in patients with hypercalcemia, and especially in patients now with malignancies and a lot of malignant anti-neoplastic drugs available. You will get hypercalcemia of malignancy very often, more often than before. That's another point. Recreational drugs, as I agree, Ghanshyam, more than the drugs per se, their withdrawal. We don't, usually this history is concealed, so you have to struggle. So the essential skills of an intensivist not only lies in understanding the CT, the MRI, but also the basic skills of interpreting an EEG should be part of like everybody now knows ultrasound, everybody now knows echocardiogram. Similarly, we should all learn about EEG, at least the basics, so that when it happens in the ICU, you can actually interpret and say this is non-convulsive status and this is my therapeutic approach. Otherwise, I think it's a fantastic talk. A lot of learning experience, learning points for all of us. Thank you.
Thank you, sir.
Thank you, Apurva.
Thank you, sir.
So thank you all for joining us. And if there are any comments or queries related to this topic, please do post them on the group from where you got this link from, and we'll answer them at the earliest possible opportunity. Join us again next week for another interesting talk on the HITS platform, and subscribe to our YouTube channel. Thank you. Have a good day. Bye.
Thank you, sir.
Thank you, Apurva.
Thank you, sir.